when you walk into a modern hospital room, there's this heavy expectation of just absolute sterility.
Right, yeah, like it's a clean room or something.
Exactly. It feels like you're walking into, I don't know, a microchip manufacturing plant. Every surface is scrubbed down. The instruments are all hermetically sealed in plastic.
You can literally smell the bleach and the alcohol in the air.
You really can.
Yeah.
And you want to believe that once you're inside those walls, you are completely safe from the microscopic world.
But we project this idea of the clinical environment as like an impenetrable fortress against disease.
Right.
But when you look at the actual biological reality of what happens inside those walls, it just shatters that fortress illusion entirely.
It really does. So, welcome to this deep dive. Our mission today is to explore this hidden world of healthcare-associated infections, or HAIs. We're pulling from this massive stack of historical medical documents, CDC surveillance data, clinical studies, and we're looking specifically at the two major threats, which are CIUTI and CLABSI.
Yeah, the big ones.
Right. And we're going to understand not just what these infections are, but how the frontline defense against them relies, less on futuristic high-tech weaponry and a lot more on surprisingly simple, empowering nursing practices.
And this is really an exploration of human biology colliding with systemic process design.
Yeah.
I mean, it's not about fear-mongering at all. It's about understanding the genuinely fascinating history of infection control and how human behavior dictates public health outcomes.
So to ground just how prevalent this is for you listening, I want to share a statistic from a CDC prevalence survey that honestly just stopped me in my tracks.
It's a heavy one.
It is. So on any given day, if you look at a typical hospital floor with, say, 30 patients, statistically, at least one of those patients is fighting an infection they acquired during their stay, not the illness that brought them to the hospital in the first place. Roughly 25 to 1 in 31 hospitalized patients is fighting an HAI right now.
And if you extrapolate that across the entire healthcare system, I mean, you are looking at a staggering volume of preventable illness.
Yeah, tens of thousands of people.
Exactly. Which means to fight this enemy, the medical community first has to agree on how to actually identify it. And that has proven to be a surprisingly monumental task.
Okay, let's unpack this definition dilemma. Because the official definition of an HAI, which used to be called a nosocomial infection, right?
Yeah. Before regulators realized these happen just as frequently in outpatient surgical clinics and nursing homes.
Right. So the definition is an infection that was not present or incubating at the time care began. But biology, unfortunately, does not carry a stopwatch.
It really doesn't.
So the CDC's National Healthcare Safety Network, the NHSN, they use this surveillance rule. Basically, for most categories, an infection counts as an HAI if the onset happens on or after the third calendar day of admission, with the day you arrive being day 1.
Ah, yes. The famous day 3 rule.
Yeah.
It is the cornerstone of modern hospital epidemiology, and it is highly, highly controversial.
I kept trying to wrap my head around why it's so controversial, and I realized it's exactly like a hotel minibar dispute.
A hotel minibar.
Yeah, think about it. If you check into a hotel, and on day 1, you notice the candy bar's missing from the fridge, the hotel assumes the previous guest took it. You don't get charged.
Okay, I thought.
But if you're there for 4 days, and on day 4 a candy bar goes missing, they are definitely charging your room.
That's actually a great way to look at it.
Right. The day 3 rule is a pragmatic compromise for record keeping. It's not some biological law.
And what's fascinating here is how that day 3 cutoff creates these 3 major contested fault lines in medicine.
Okay, lay them out for us.
So the first one is present on admission versus facility onset. That day 3 rule roughly approximates the incubation period for common pathogens, right? But it inevitably misclassifies cases on the margins. You could get infected in the emergency room on day 1, show symptoms on day 2, and technically dodge the official HAI label.
Wow, okay.
Or you could be carrying a bacteria when you walk through the front doors and only show symptoms on day 4 from something you actually brought in yourself.
Because insurers and regulators demand a bright, clean line for billing. But like we said, biology just does not respect calendar days.
Exactly. Which brings us to the second major fault line, colonization versus infection.
Right, because what if I'm just naturally carrying a bacteria? Like, I might have something on my skin right now that isn't making me sick, but it could trigger a positive test.
Spot on. You can carry a pathogen, say, methicillin-resistant Staphylococcus aureus, or MRSA, which is a highly antibiotic-resistant superbug.
Right, a really nasty one.
Yeah, and it can just live happily in your nasal passages without making you clinically ill. That's colonization.
Okay.
But if hospitals count every colonized patient as an infection, they massively inflate their rates. They end up looking incredibly dangerous on paper.
But on the flip side, if they ignore colonization entirely, they might miss a patient who isn't sick themselves, but is actively transmitting that superbug to, a really vulnerable patient in the next room.
Exactly. They have to distinguish between simply harboring a bacteria and actively suffering from it.
Which seems incredibly difficult to do at scale. So what about the third fault line? What happens when someone has a medical device?
Right. Device attributable versus incidental infections.
So say a patient gets a tube placed in their chest, and 3 days later they have a bloodstream infection. How do we definitively prove the device caused it, rather than some other underlying issue?
Well, the CDC uses incredibly strict checklist-style criteria to determine if a device actually caused the infection.
Because if they didn't, it would just be totally subjective.
Right. Relying on clinical judgment alone resulted in wild variations from hospital to hospital in the past. But, and this is but the rigidity of that checklist means some genuinely device-caused infections might slip through the cracks if they don't check every single box on the form.
Which sets up this massive tension between the clinical reality and the financial reality.
Mm-hmm.
And I really want to look objectively at the 2008 U.S. Medicare policy shift here, because it fundamentally altered how hospitals operate.
It's a massive shakeup.
It's huge. In 2008, Medicare stopped reimbursing hospitals for the extra costs of treating certain reasonably preventable HAIs.
Mm-hmm.
And on one side of the debate, you have policymakers who instituted this to drive accountability. The goal was to financially incentivize hospital administrators to improve patient care and take prevention seriously. Like, if a patient gets an infection on your watch, you pay for the treatment, not the taxpayer.
And honestly, the logic there is very sound from a regulatory standpoint.
Absolutely. But then you have the critics of this policy, particularly the frontline infection preventionists, and they argue it created a perverse financial incentive.
Right, because when millions of dollars are on the line, behavior changes.
Exactly. The argument is that clinicians now face immense pressure to game the numerator, so to speak. There's an administrative push to aggressively label any ambiguous infection as present on admission.
Or to just underdiagnose borderline cases entirely to avoid those financial penalties.
Yeah, which shifts the focus from genuinely improving preventative care to mastering the art of defensive documentation.
And it's wild to think about how intensely we are struggling to define and track and argue over the paperwork of these infections today, considering the history here.
Oh, the history is incredible.
Yeah.
The very first massive breakthrough in preventing HAIs happened decades before anyone even knew what a germ was.
Yeah, the historical context here is critical. We really have to rewind to 1847.
The story of Ignaz Semmelweis. I love this story. So he's a Hungarian obstetrician working at the Vienna General Hospital, right?
Mm-hmm. Mm-hmm.
And he notices this horrifying discrepancy. In the maternity ward, staffed by male doctors, the maternal mortality rate from puerperal fever, which they called childbed fever, was roughly 18%.
Almost 1 in 5 women dying.
Just staggering.
Mm.
But right next door, in the ward staffed by female midwives, the mortality rate is only about 2%.
A difference of life and death, entirely dependent on which door a pregnant woman walked through.
Right. So Semmelweis realizes the male doctors are coming straight from the autopsy room to deliver babies, and the midwives aren't doing autopsies. But germ theory doesn't exist yet. Nobody knows what bacteria is. So he blames what he calls cadaverous particles.
Cadaverous particles. It sounds so archaic now.
It really does. So he mandates that doctors have to wash their hands with a chlorinated lime solution before examining the women. And within a year, the mortality rate in the doctor's ward plummets from 18% down to 1% to 2%.
It is arguably the first controlled natural experiment in HAI prevention. I mean, he proved that the physicians themselves were the vector of disease.
He proved it, and the medical establishment completely ignored and ridiculed him.
They were highly offended.
They were. They thought it was an insult to a gentleman's hands to suggest they were dirty or carrying particles. He was driven out of the hospital, and he ended up dying in an asylum in 1865. And in this tragic twist of irony, he actually died from a wound infection.
Oh, wow. I didn't know that part.
Yeah. He wasn't vindicated until Louis Pasteur and Joseph Lister definitively proved germ theory years later.
And right around that same time, during the Crimean War, so this is between 1854 and 1856, Florence Nightingale was making very similar breakthroughs, but she was doing it through the lens of statistics.
Right, she was a data pioneer.
She really was. She utilized her famous rose diagrams, which were essentially early forms of statistical data visualization, kind of similar to pie charts.
Okay.
And she used them to prove to military generals that soldiers were dying far more often from hospital-acquired diseases like dysentery and typhus and cholera than they were from their actual battlefield wounds.
That's incredible.
She forced massive sanitary reform simply by visualizing the data.
So they were fighting the invisible enemy and winning, without even knowing what the enemy actually was.
Because at a fundamental biological level, they were disrupting the chain of infection.
Okay, break that down for us. What is the chain of infection?
In modern epidemiology, for an infection to happen, a literal chain of events must occur. You need the infectious agent. It needs a reservoir to live in.
Like a dirty surface or a person.
Exactly. Then it needs a portal of exit, a mode of transmission, a portal of entry into the new body, and finally, a susceptible host.
So when I walk into that modern hospital room from our intro, all that plastic wrapping, the gloves, the bleach, that is just the hospital systematically targeting different links in that chain.
Precisely. Semmelweis was breaking the mode of transmission by washing the doctor's hands. Sterile technique blocks the portal of entry. Modern infection control is essentially just the systematic severing of that chain.
That makes so much sense.
But despite those early breakthroughs in the 1800s, it really took until the late 20th century to prove to modern hospitals that this chain could be broken systematically on a large scale.
Right, which brings us to the Scenic Project.
Yes.
This was a monumental effort from 1974 to 1983. The CDC ran this study on the efficacy of nosocomial infection control across hundreds of hospitals over a decade.
A massive undertaking.
Huge. And they proved definitively that hospitals with dedicated surveillance and control programs, meaning they had dedicated staff whose only job was tracking and providing feedback on infections, they reduced their infection rates by a third.
Which is a staggering public health victory.
It is. And the hospitals without those programs, they actually saw their rates rise over the exact same period.
And that study forced a complete paradigm shift in medicine, because before Scenic, a hospital infection was largely viewed as an unfortunate but unavoidable cost of doing business. You know, if you put sick people in a building, some will just get worse.
Right.
Scenic proved that an infection is a measurable, preventable event. It is a failure of process.
Which brings us out of the history books and onto the modern clinical battlefield. Because today, the primary threat isn't a doctor walking in directly from a Victorian autopsy suite.
No, thankfully.
The front lines of this battle today are the medical devices we deliberately leave inside patients. So let's break down the big two, CAUTI and CLABSI.
Right. These two devices dominate hospital policy and prevention efforts. CIUTI stands for Catheter-Associated Urinary Tract Infection. And historically, this has been the single most common type of HAI in U.S. hospitals.
And the frustrating part of the research is learning why it's so common. Foley catheters are often placed, and more importantly, left in, simply for staff convenience.
Yeah, that's a hard truth.
It is. It makes nursing care easier if a patient doesn't need to be helped to the bathroom, rather than there being a strict, ongoing medical necessity for the tube.
And the danger lies in the cumulative risk. Every single day that urinary catheter remains in place, it adds a compounding percentage point of risk for bacteria to enter the bladder.
It just ticks up every day.
Exactly. A catheter left in for a week carries a substantially higher risk profile than one removed after 24 hours. The human body is simply not designed to have a permanent plastic conduit to the outside world.
And then you have the more dangerous counterpart, CLEBSI, which is central line-associated bloodstream infection.
Right. Numerically, CLABSI is far less common than COUTI, but it is vastly more lethal.
Because it goes straight to the heart, right?
Basically, yes. We are talking about a central venous catheter, a long tube threaded directly into a large vein, often ending just outside the heart. It's used for delivering potent medications or nutrition. But if bacteria or fungi enter the bloodstream through that line, the infection has immediate access to the entire body. Historically, the attributable mortality rate for CLABSI has been estimated between 12 to 25%.
It's terrifying.
It is. And it also adds tens of thousands of dollars and extended intensive care days to a single patient's stay.
You know, I want to address something that people naturally assume when they hear about hospital infections.
Yeah.
It's so easy to think that only immunocompromised people or patients who are already incredibly weak get these infections.
Right. That's a very common misconception, yeah.
Right. But I like to think of your immune system like the thick stone walls of a medieval castle. You might have the strongest, thickest walls in the world. You might be a young, incredibly healthy athlete. But if you leave the drawbridge down and the front gate wide open, the invading army is just going to walk right in.
That is a perfect analogy. A central line or a urinary catheter is a mechanical drawbridge. It completely bypasses the body's natural defensive barriers, the skin and the mucosal linings.
Right.
Anyone with one of these devices is at severe risk, regardless of how robust their underlying immune system is.
It's a mechanical failure, not just an immune failure. Which leads to another major assumption. If someone gets an infection in a hospital, the immediate reaction is, oh, the hospital must be dirty, the room wasn't cleaned properly.
And environmental cleanliness is obviously a baseline requirement for any medical facility. However, looking at the data, environmental surface contamination is not the dominant driver of these device infections. Really, a spotless, highly sterilized room where an unnecessary catheter is left inside a patient for 10 days is vastly more dangerous than a merely adequate, normal room where the medical device is removed promptly.
Wow.
The duration the device remains inside the body is the absolute primary risk factor.
So, if the duration of the device is the biggest risk factor, how do hospitals actually solve this? I mean, you would assume that in the 21st century, with billions of dollars in research, the solution would be some massive technological invention.
Right, like some robotic, AI-driven, self-cleaning catheter.
Exactly. But the most effective tool turned out to be a laminated piece of paper.
It really did. You're referring to the Keystone ICU project in Michigan, which ran from 2003 to 2006.
Yeah.
A critical care physician named Peter Pronovost implemented a ridiculously simple 5-item checklist for CLABSI prevention across more than 100 intensive care units.
5 simple behavioral steps. I have them right here. Hand hygiene, using full barrier precautions during the insertion of the line, using chlorhexidine to clean the patient's skin, avoiding the femoral vein in the leg, which I guess has a higher infection risk, and prompt removal of unnecessary catheters. That's it.
And the results were published in the New England Journal of Medicine, and they were just staggering. The median CLABSI rate across those Michigan ICUs dropped by roughly 2/3 within 18 months.
That's unbelievable.
Many intensive care units hit 0 infections and stayed at 0 for months on end.
And this intervention cost almost nothing. It wasn't a multi-million-dollar technology upgrade.
Because the brilliance of the Keystone Project was that it engineered a culture change rather than a technological one.
Right.
The real power of that laminated checklist was that it fundamentally shifted the medical hierarchy. It gave a bedside nurse the explicit systemic authority to stop a central line insertion procedure, even if it was being performed by a senior veteran surgeon, if a single step on that checklist was skipped.
Overcoming that deeply entrenched hierarchy was the actual breakthrough.
Exactly.
And here's where it gets really interesting. Compare the success of that cheap checklist to the high-tech alternatives the industry tried to push.
Oh, the tech push was massive.
Right. Throughout the 2000s and 2010s, medical supply companies were heavily marketing these incredibly expensive antimicrobial and silver alloy-coated urinary catheters. They were pitched as the ultimate technological silver bullet for CAUTI.
And the premise was that the silver would actively kill bacteria on the tube.
Mm-hmm.
But large clinical trials consistently showed that those expensive high-tech fixes underperformed. At best, they barely match the results of cheap nurse-driven behavioral protocols.
Just basic protocols won out.
Yeah. A hospital protocol that empowers a nurse to automatically pull a catheter when a patient meets specific clinical criteria without having to wait hours for a doctor to write an order that does infinitely more to prevent a biological infection than a silver-plated tube ever could.
So we have this proven blueprint. Empower the staff, follow the behavioral protocols, remove the devices quickly.
Right.
But that only works when the hospital system isn't under crushing strain. And it only works when clinicians don't accidentally overcorrect out of fear.
And if we connect this to the bigger picture, that fear of missing an infection has led to a massive controversy in hospital medicine right now.
The overtreatment trap.
Exactly. Specifically regarding a condition called asymptomatic bacteriuria.
Okay, so it is crucial to understand that just because a laboratory finds bacteria in the urine of a catheterized patient, it does not automatically mean they have a CIUTI.
Correct.
To officially be a catheter-associated urinary tract infection, you need the presence of bacteria, but you also need clinical symptoms: fever, localized pain, elevated white blood cells.
Yes.
Because a huge percentage of patients with catheters have bacteria just hanging out in their bladder without causing any actual harm or sickness.
But hospitals are intensely scrutinized on their CIUTI rates. They are terrified of being penalized. So there is a systemic tendency to overtest the urine, even when the patient feels completely fine.
Just constantly checking.
Yeah. And they find the harmless bacteria, they panic, and they immediately treat it with prophylactic antibiotics.
But I don't get why we can't just pump the patient full of antibiotics to clear the line as a preventative measure. Why is giving routine antibiotics for asymptomatic bacteria a bad idea?
Because it doesn't actually prevent line and catheter infections. What it does do is fuel the global antimicrobial resistance crisis.
Okay.
You are simply training the bacteria in that hospital to become immune to our strongest drugs. And the reason antibiotics struggle so much with these specific device infections comes down to something called biofilms.
I want to visualize this. A biofilm isn't just a layer of germs, right?
No, it's more structured than that. Think of a biofilm as a microscopic slime city.
Slime city. Okay.
Yeah. When you insert a foreign object, like a plastic tube, into the warm, nutrient-rich environment of the human body, bacteria recognize it as a prime piece of real estate.
Because it's a safe surface.
Exactly. So they attach to the surface of the plastic, and they immediately begin excreting this sticky, protective, extracellular matrix over themselves.
Like building a dome.
Literally. This slime shields the microbial community from the patient's circulating immune cells, and it acts as a physical barrier against antibiotics.
So the antibiotic medication is just floating through the patient's bloodstream, but it literally cannot penetrate the slime city on the plastic tube to kill the bacteria inside.
Exactly. Once a mature biofilm forms on a central line or a catheter, attempting to eradicate it with intravenous antibiotics is often an exercise in futility. The bacteria are just too heavily entrenched in their matrix.
Wow.
That is the fundamental biological reason why the physical removal of the device is vastly superior to trying to medicate your way out of the problem.
That makes total sense. But doing all of this, successfully executing the checklists, empowering the nurses to demand prompt removals, conducting the careful auditing of device necessity that requires a hospital system that is functioning like a well-oiled machine.
It does. It requires immense systemic discipline.
And we recently saw a devastating real-world example of what happens when that systemic discipline breaks down.
We did. The COVID-19 pandemic served as a truly heartbreaking stress test for modern infection control.
Between 2020 and 2021, the CDC's NHSN data showed a well-documented, just catastrophic reversal of years of hard-won progress in reducing CLUTI and CLABSI rates across the country.
The entire system just buckled. You had severely overwhelmed staffing ratios where nurses were managing far more critical patients than safely allowed.
Right.
There were massive shortages of personal protective equipment, the basic gowns and masks needed to even enter a room safely.
It was chaos.
It was. And patients with severe respiratory distress were being placed in prone positions, meaning they were flipped onto their stomachs to help them breathe on ventilators.
Oh, wow. And managing the sterile fields of central lines and urinary catheters on a patient lying on their stomach is incredibly difficult. And crucially, routine infection control audits were entirely suspended.
Because the dedicated staff who normally track those infections were pulled to the front lines just to help the hospital survive the shift.
Exactly. And what this starkly demonstrated is that HAIs are not a fixed, inevitable property of medicine. They are a direct, real-time reflection of process discipline.
Because the moment the systemic discipline eroded under the strain of the pandemic, the infection rates immediately skyrocketed.
Exactly.
So why should you, listening to this, care about the difference between colonization and infection, or the minutia of the day 3 surveillance rule?
It's a fair question.
Right. Well, beyond the immediate, terrifying risk to yourself or a loved one if you are admitted to a hospital, these infections cost the healthcare system tens of billions of dollars annually. They require extended hospital stays, highly toxic secondary treatments, and they are a massive drain on finite medical resources. Furthermore, they are a central battleground for the antimicrobial resistance crisis. Every single unnecessary catheter left in for an extra day, every unnecessary course of antibiotics given to a patient who didn't actually have symptoms, it all adds immense evolutionary pressure to an already terrifyingly strained arsenal of effective antibiotics.
But there is a deeply empowering takeaway from all this data, especially regarding how modern healthcare is actually delivered. This deep dive shows that bedside nursing practice is the primary driver of population-level public health data.
Absolutely.
We tend to focus on the doctors writing complex orders or the lab scientists developing experimental new drugs. But the reality of infection control is the nurse executing the care bundle at 3 a.m.
Yes.
Is the nurse doing the daily assessment, asking, does this patient still critically need this central line? Is the nurse physically pulling the catheter out? They are the ones actually severing the chain of infection.
It is a potent reminder that sometimes the most sophisticated medical intervention we have is human diligence and behavioral discipline, which, actually, raises an important conceptual question for us to consider as we look to the future of medical engineering.
Okay, what are you thinking?
Well, we've established that the duration a device stays in the body is the ultimate risk factor, and we know how quickly these biofilms can form to shield bacteria from our strongest drugs.
Right, the slime cities form fast.
Exactly. So if a microscopic slime city can form on a standard plastic medical device in a matter of hours, how might the very materials we use to manufacture future medical devices need to fundamentally change?
So that's interesting.
Instead of just providing a sterile, inert plastic highway for bacteria to travel on, perhaps the biomaterials of the future will need to actively mimic the human body's natural dynamic defenses.
So instead of relying on a plastic tube in a perfectly sterile room,
Yeah.
we engineer a device that fights back the way our own skin does. Because right now, we are heavily relying on that expectation of a pristine fortress. But biology always finds a way in. Thank you for joining us on this deep dive. Keep questioning the invisible systems around you, and we'll catch you next time.